When life gets unpredictable, preparation matters. In medicine, it's all about staying alert, ready for whatever comes through the door. On the road, it's no different. That's why Volvo designs vehicles to help anticipate risk, reduce harm, and protect lives. The Volvo XC90's advanced safety systems inspire confident decisions wherever the road takes you. The Volvo XC90, for life. Proud sponsor of the Pit Podcast. Learn more at volvocars.ca/safety.
The opinions expressed in this segment are those of the commentators. As the information surrounding COVID-19 is constantly evolving, you should check with your own healthcare provider regarding your specific situation. If you believe you have symptoms, contact the appropriate authorities. Getting to the bottom of a story, even if it means going straight to the top. Elias Makos, CJAD 800.
Well, could a new drug to treat COVID-19 only cost $1? Just one of the things we'll discuss with Dr. Frederic Dankoff, physician at the MUHC. Dr. Dankoff, thank you so much for joining us on the show.
My pleasure.
And if you've got a COVID-19 medical question, you can give us a call over the next little while, 790-0800, 514-790-0800, but still plenty to discuss. Dr. Dankoff, first thing, we've heard of this drug, remdesivir, correct? I'm saying that right?
Correct, yeah.
It's been approved in the U.S. In the fight against COVID-19. It has shown some success, right, in clinical trials?
So the success was actually in the reduction of the length of stay or severity of the disease. Sadly, we didn't see a great reduction in mortality. I think the NIH result was out either the last day of April or the 1st of May.
Okay, and when we look at that reduction in let's say a hospital stay, what kind of improvement did we see? And would this be something that our healthcare system could look at as a sort of cost-efficient way of reducing hospital stays?
It's not very clear. So even at the of the drug use, there's a bit of a history there in how they got to an approval. Initially, it was approved for a little while for compassionate measures. Then they said, well, no, we have to keep it for research in order to get results in the first place. And then at that point, they decided to grant it the emergency use authorization. I think that was May 1st for the FDA. Mm-hmm. And even then, it's still only for severe cases. If we're looking at, let's say, here in Quebec, where we're still able to keep up with the ICU bed need, that's the kind of patients we're looking at. It's difficult to say without a good proof of change in mortality or that it doesn't cause any risks that this is actually something that's going to help us to manage the actual resources we have.
And I guess when it comes down to it, when we look at COVID-19, obviously there's focus on getting a vaccine and there's focus on getting a treatment. As you see it, when it comes to treatments, is there anything that you're seeing that you're sort of hopeful or positive, or is this just, if you test positive, you end up in the hospital, it is just a lengthy process and doctors and nurses, everyone's just doing the best they can?
For now, I would say, the experience from the front line is you test positive and you're sick, then you end up in the hospital. Mm-hmm. Let's not forget the amount of people that test positive for the virus or may even have the virus that have little to no disease. And then all the other weird stuff that we're starting to see, the U.S. talking about strokes in 20 to 50-year-olds with no other risk factors. In terms of what we're able to do, it's not a disease right now that we can see as a cure. And even if we get something that is going to be very helpful, short of being fully immunized, the mainstay of the disease is still in supporting the patient, providing oxygen, making sure they're safe, providing, the same thing that we would do for any patient with a severe sepsis. I'm not seeing anything coming soon where 90% of the patient's treatment is still not going to be taking care of their respiratory system, their cardiovascular system.
We're with Dr. Frederic Dankoff, physician at the MUHC. Interesting story, Dr. Dankoff, about this world-first treatment that's being studied right here in Canada, in London, Ontario, and it's called a COVID-19 dialysis treatment. Now, the only other time I've heard the word dialysis is when it comes to kidney dialysis. Can you explain what this is, what this hopeful treatment is?
Sure. So we'll start a bit at the beginning, which is the virus itself has pretty much two different phases. There's a viral phase where you have the virus, but one of the thoughts right now in terms of all the pathology we're seeing is more the inflammatory phase. This is where your immune system turns on and causes most of the bad disease that we're seeing. whether it's the weird clotting or the strange effects on the lung, et cetera, that's actually mostly the inflammatory issues. What the researchers in London were doing is essentially trying to treat your white cells, your body's immune system, so that it doesn't inappropriately respond with this over-emphatic inflammatory reaction. And the idea here is to treat what's called a cytokine storm or cytokine release syndrome, or essentially an over-release of immune mechanism where you're causing all kinds of issues to yourself. It's like being overly inflamed when you're trying to just, treat yourself for a cold. You can cause your own disease at that point.
Doctor, what's the situation in hospitals when it comes to elective treatments? I keep getting a ton of questions about, I have this procedure planned, or I need to get this test. Should I go in? What's happening now at the MUHC? Are you starting to try and get back to previous levels when it comes to that kind of elective stuff, the testing and stuff that's not COVID-19 related?
That is so tough. We keep looking around the corner to see where we're going. We have all of us, especially the institutions that are holding back on complex care like cancer, et cetera. We have to ask our questions, those same questions every day. We have to look at the pattern. We have to also follow what's happening in the province. I wish I had very clear answers, but I don't. In fact, it's even brought up more questions. So I'll give you an example. We've held our cancer surgeries, and we know that we have to work on those. But now we're thinking to ourselves, wait a second, what about that patient who was waiting for the biopsy or just a simple ultrasound of a breast mass? Could that be somebody that is on top of that now late for a potential cancer treatment? So it's question upon question upon question, dependent on resources that we can't confirm right now. So it's not an easy question. We're not yet at the point where we're ramping up everything. We are looking at ramping up some activities, but we've got to be really careful to make sure we hit on the things that are really priorities.
Man, what you're just describing right there, and the provincial government had said in its daily press briefings, I specifically recall Danielle McCann saying, the urgent treatments, they're not being delayed. Those will continue. But what you're telling me is that, just of the matter of course, if you're going to delay certain tests and biopsies, these things are being delayed, right? They may not be expressly being delayed, but there are ramifications to other things, other processes, other biopsies and tests being delayed, right?
Yeah, absolutely. I mean, look, we learned this in SARS, and I think we're better at it this time. And when I say SARS, I mean the original. The SARS report written in Canada specifically literally said you have to be really careful about all the other morbidity, all the other bad things we cause to people when you're taking care of something that's terribly bad that keeps everybody occupied. The truth is, we are, just like you said, anything that's really like priority one is still getting done. And even then, we're thinking of things that are maybe not priority one, but can turn into a priority one, either from delay or because when you get those results, they become priority one. Yeah. So it's changed a lot of how we're thinking through things. And not only that, we keep repeating since day one, this is not a sprint, it's a marathon. And when you start thinking of marathon, you start thinking of things that impact things that impact things that impact things. So our questions become multi-layered, and honestly, we're asking more questions right now than we're answering, but at least by answering the right questions, we're reaching into those odd little things that we want to make sure we don't miss.
We're going to squeeze in one question from a listener. Deborah is in DDO. Hi, Deborah.
Hi.
Hi, what's your question?
I'd like to know what causes the loss of smell, and how long does it last for?
The nausea. The only thing I can say is it's a symptom that is so clear for patients in terms of having the COVID-19. You know what? Because it's not usually pathologically dangerous, I've not looked at the cause. If I'm on again, I'll try and bring all my answers, but honestly, I'm not exactly certain. We know that there's discrete inflammatory changes that can happen everywhere. In fact, you can even get a small area of inflammation in the heart that causes arrhythmia. So I'm going to guess that in that area of the nose, there's a very local area there. If you get inflamed, it can dysfunction. But I can look it up, or I really don't have the answer for the anosmia.
Thanks, Deborah, for the call. And Dr. Dankoff, you bring up a good point, right? There's so many different facets of this. If you're looking at one of the symptoms that, isn't necessarily one of the worst symptoms of COVID-19, less focus is on that, clearly. Thanks so much for coming on the show. I appreciate it.
Pleasure.